at peak. Uh,
Yeah, started acting on it.
so,
So Rajesh, you're presenting first.
Hi, how are you?
Hi. Good.
He is from
Ankit has
Norway.
joined.
Ankit.
Is joining from Tromso.
Oh, you're
Is
in Norway. Oh,
Ah,
so I didn't know that.
Who's joining from Tromso?
Ankit.
Ankit.
अरे वाह अंकित
ah,
Venkat,
yes.
Hmm.
Is it?
तुझे तो ऐसा डेडिकेटेड अवार्ड देना चाहिए
It's very
आर्टिक सर्कल पे जाके
nice.
वेबिनार में लॉन्च व्हाट टाइम इज इट देयर आफ्टरनून
So yeah, so over here we are 4.5 hours behind India. तभी वहाँ पे 8:30 है, तो इधर दोपहर का 4 बजे है, शाम का 4
Good.
बजे है. So
Good. How is it? Did you get those flashes?
yes,
Aurora.
yes. I saw it yesterday.
So
I saw it yesterday night.
capture
Yes.
किया तो फोटो भेज.
I'll send it.
You should go and chill outside.
Yeah.
I
Actually, the
think
weather is really nice. The weather is nice outside.
No,
We
go.
need half of that weather in Bombay. Half of that. Full नहीं चाहिए. Good.
maybe he is waiting for the evening or night so he can have a look at northern lights again.
Well, it's not
Nothing,
actually that
nothing much to
simple.
nothing much
Yeah.
to do in daytime, except just move around.
Actually, daytime, वो थोड़ा a lot of people come here for skiing. Skiing is a big thing. A lot of people come here for that.
Yeah.
It's a small place as such. So, once you-
How is it? Very cold or manageable?
No, मतलब 2 degrees, 3 degrees,
Okay.
sometimes 0. Yeah. So, yeah, manageable. So that fine.
तुझ्याला पाठव पटकन.
Great.
It's almost time.
Yes.
Should we start?
So,
or?
Rajas, this
I think
Sunday we have.
Yes, sir. Yes, sir.
So this Sunday we have in Sion Hospital,
Yes, sir.
wrist and
Yes.
hand,
Yes, sir.
all set.
Yeah.
तो आया है
Presentation is clear, बाकी थोड़ा. So he told me they're going to get some cases also. I think they are trying to.
अच्छा.
Okay.
So I just messaged him a couple of days ago. So I think
से थोड़ा साफ करेंगे अरे सीसी
What is RCC?
मैंने ना टेस्ट डाली मैंने कहा कि ना वो टेस्ट हाँ RRCA प्रचन्ना रानाडे
I think we can start.
Yeah, we can start. I
Rajas?
think it's 8:30.
Yeah, we should start. Yes.
So I'm just requesting everyone to put their mics on mute, and any queries you have, please type it in the chat box, and we'll try and get back to it post the lectures.
अरे ना ध्यान मत
Just requesting everyone to mute, please. Yeah, Dr. Mohit, you want to say something?
Yes, I want to introduce you. I want to do that honors of introducing Dr. Rajesh Chaubal. So I cannot say new kid on the block because he's not a kid anymore, but he's a rising star, something that we used to tell Ankit. So all of these, youngsters are now coming to the forefront, the main torch bearers, and I'm proud to introduce Rajesh, whom I've known for many years. He's an exceptional orator, and I'm very excited to hear his talk on peroneal tears. So, Rajesh, on to you. All the best.
You, and I think it's a privilege for me to have been introduced by you. So thank you very much. Okay, so what I'm going to do is it's just a very simple case, right? But I'm just trying to show how we apply all these in our clinical practice, in our day-to-day practice. So I'm going to show you the just as got it, the way we approached it, and what we did. Okay. So just let me turn on my screen share. Sorry. Okay. So I think everyone can see my screen. Is that okay?
Yes, yes, it is okay.
Just
Can
requesting
you
everyone,
please
please,
mute, please?
your mute mics on mute, please. Okay, thank you. Okay, so this was a case we saw just a couple of weeks back, and this was a middle-aged female who came with pain over the lateral aspect of the ankle, just posterior to the malleolus. And this was there for a few weeks. I think she said about 2 months. There was definitely swelling. There was some tenderness. We asked her about any history of injury in terms of twisting or something, but she wasn't really sure. She wasn't very sure. So for all practical purposes, there wasn't any injury or twisting of the ankle. Now, the good or the bad part was the MRI was already done, right? So this is kind of a reverse scenario that we really faced. And I'm just putting up the MRI report, which said that there is a hyperintense lesion in the tendon sheath of the peroneus, tendons in close proximity, causing thinning of the peroneus brevis tendons as mild restricted diffusion, minimal internal enhancement, marked peripheral enhancement, and inflammation. And if we look, and they give these three possibilities of a tendon sheath fibroma, a tenosynovial GCT, or inflammatory pathology like chronic tenosynovitis. Now, honestly, at the end of all this, the clinician was still confused. He didn't know what we are really looking at. So he told us, please have a look. So when this patient came to us, we already had the MRI, so we had seen the MR report. So we were going to proceed with a little bit of a caution. So when I started scanning on the lateral aspect of the ankle, what I came across first is, yes, there's definitely some thickening of the tendons. There's some adjacent inflammation. Could definitely see that mild fluid around the tendons. And also I had a look at the superior peroneal retinaculum, which appeared quite intact, if you can see over here. Sorry, you'll have to bear with my voice. I've got a bad throat. And now, because they had mentioned about all this internal vascularity on the MRI, I was trying hard to, first actually find a lesion. So I was trying to see if there's any lesion. I could see some thickened area over here. I tried to see it with power Doppler. There was no flow. Luckily, I had the availability of microflow imaging. I couldn't really appreciate any flow with that as well. So I was still not very sure what exactly we were trying to correlate what was said in the MRI. So I said, okay, let's pull back. Let's have a look at this properly. De novo, let us not get biased with the MRI report. And I just want everyone to observe this clip for a few seconds. On this again. Okay, just go over this clip and I'll discuss this with you very shortly. Okay, so any usual, unusual features? So to begin with, yes, there was definitely some component of tenosynovitis. The tendon was looking thickened. There were some inflammatory changes, like we said, but something was amiss over here. Uh, Normally, we only see two tendons, but I was able to see some three structures over here in the retrofibular region, right? So we were little wondering as to what this is. Is this the region that they've reported in the MRI? What exactly is happening? So I decided, okay, let's make best use of ultrasound. Let's go on to the other side, see what is happening over there. And as I did expect on the left side, I could see there were only two tendons. I could see the peroneus brevis and the peroneus longus, exactly what I expected. And then I went back to the right side to, see this again, compare with the left, compare with the normal side. And what I saw was this. Sorry. pulled, as we went proximally, right? As we started scanning from the proximal aspect, what we are able to see is that this is the peroneus brevis muscle, right? So I'm going proximally into the distal aspect of the calf. Okay, what I'm seeing here is the peroneus brevis muscle. Over here, this is already the peroneus longest tendon which is formed. So now just observe this muscle and just trace it as we come down, right? So as we come down, what is happening somewhere at this level is you can see actually this muscle is kind of splitting up over here. Can you appreciate that? This is like a U shape, which should not normally be seen, right? So you see that there is split in the muscle over here. And this peroneus longest tendon. I'm going to go back and forth on this clip a little bit. So bear with me. So this is the peroneus longest tendon. You can see that the peroneus brevis is kind of split up, and the peroneus longest tendon is sitting bang over here, right? So again, so this is what you normally expect in the proximal aspect of the distal aspect of the leg. So as we saw proximally, we can see the muscle over here, the peroneus brevis muscle, the peroneus longus tendon. And as we come distally, like I showed, the peroneus brevis was actually splitting into two parts, right? I'm going back to the old clip. Okay, the peroneus brevis is split into two parts, and you have the peroneus longus sitting in between. So this was the appearance which we were getting in the retrofibular groove, right? So we came to a conclusion that, okay, this is probably a longitudinal tear of the peroneus brevis. Longitudinal tears of the peroneus brevis are not that unfrequent when you're looking at patients with, they've been having chronic lateral ankle pain or instability. We should be aware of, and I'll also tell you why a little shortly. So just to recap the anatomy on the lateral aspect of the ankle, we try and evaluate the lateral aspect of the foot flat on the surface. We keep a little bit of a mild internal rotation, and we go and image in the retrofibular groove. Now, as we image in the retrofibular groove, the tendon or the muscle that we first see closest to the fibula.
Rajesh, can I stop you for a minute?
Yes,
Yeah.
ma'am.
Can I request everyone to please mute themselves, because there is a background noise and there are a lot of listeners who are having difficulty hearing Rajesh. Can we have everyone mute themselves, please? Deepthi, requesting Deepthi Patel, please mute yourself. Thank you. Rowley, can I have you please mute yourselves? There's a background noise and there are a lot of people who are saying that they can't hear very clearly. Thanks, Rajesh. Please go ahead.
If there's anything you want me to repeat, please let me know. I'll happily go ahead and do that again.
This is for Sandy and one more person. Do you want us to repeat or should we go right ahead? We go right ahead?
Okay.
Okay, all right.
So we just
टिकेगा
recap.
कैसा मैडम ऐसा थोड़ा है रिपोर्ट
है शालिक, क्या बोले? Shalik? Shalik, can you please mute yourself then? There's a lot of background noise. Shalik Adi, please mute yourself. Thank you.
जाना देना फिर वो नहीं करनी ठीक है ना जब आने तो बैठे ठीक
Okay. So
Dear Shalik, can you please mute yourself?
I think
Thank
these.
you.
Thank you. Okay. Thank you. Okay. Sorry. So I'm just going to recap the anatomy. So when we start looking at the lateral aspect of the ankle, which is one of the relatively easier, aspects of the ankle to look at, we keep the foot flat on a surface and we give a mild internal rotation, right? Then we go and image in the retrofibular groove. And as we image in the retrofibular groove, this muscle or the tendon which is closer to the fibula, that is your peroneus brevis. And the tendon which lies on top over here is your peroneus longus, right? So you have the peroneus brevis deeper down and you have the peroneus longus on the most superficial aspect. And the other important thing is that these tendons are stabilized by the peroneal retinaculum. right? So you can see this hypoechoic line which covers the tendons, and this is what stabilizes the muscles and the tendon in the area. You also have an inferior peroneal retinaculum, which is seen a little more distally. Now, as we start looking at these tendons in an axial section, right? So this is my scanning plane. I'm looking at it in the axial section, and I'm going more distally. What happens is that somewhere at the level of peroneal tubercle, these tendons change their directions, right? So initially they are contained within a common sheet. The sheet splits, and these tendons, you can see now they're traversing in different directions. You have the peroneus brevis, which is going flat and towards the fifth metatarsal. And I'm going to run this again, and you can see the peroneus longus tendon dipping down, as you'll see over here shortly. Yeah, see, this is the peroneus longus tendon dipping down, right? So the peroneus longus tendon actually inserts on the lateral surface of the medial cuneiform and the first metatarsal. So this is actually on the plantar aspect of the foot, right? So peroneal tendon, it comes from the lateral side, it goes below the foot and inserts onto the first metatarsal. And it is the action of this is basically plantar the first metatarsal. Now the peroneus brevis, what happens is this goes around the peroneal tubercle. It has a more horizontal.
Dr. Gino, can you just keep your thing up? Dr. Gino?
Sorry. Okay. So it goes and it inserts onto the base of the fifth metatarsal, and it acts as a primary everter of the foot. Right? So what happens when there is a longitudinal split tear, or why does this really happen? So there are a couple of mechanisms which have been proposed. A good number of times this is because of mechanical irritation. So what happens is your peroneus brevis is close to the lateral malleolus, right? And there is when the peroneal longus contracts, right? It pushes this muscle against the lateral malleolus, right? So eventually this chronic irritation can lead to a defect. Once this defect happens, the peroneal longus actually sits in this defect. And as a result of which, this can even not allow the peroneus brevis to heal properly, right? So eventually it causes a chronic tenosynovitis, leading to all the symptoms of pain, swelling, etc. Also, another mechanism where this can get injured is when you have an inversion injury. And invariably, this can be associated with injury to the ligaments also. So you have the talofibular or the calcaneofibular ligaments injured, or there can be injury to the peroneal retinaculum as well. There are some other causes as well why this happens. There can be subluxation of the peroneal tendons, ligament instability we spoke about. There can be an enlarged peroneal tubercle which causes this problem. You can have a distally located muscle belly of the peroneus brevis, which can also give rise to this tear. And then at times you have this accessory muscle of peroneus quartus, which can again, precipitate the tear. So in fact, if there is the presence of this muscle, there is, almost 2 times to 4 times likelihood that this will increase. Okay, the chances increase by 2 to 4 times. So what do we see on ultrasound? We have already seen the findings. We can see that the peroneus brevis is split, as we can see over here. You have the peroneus longus sitting in over here. And the good thing is accuracy for diagnosing these tendon tears on ultrasound is nearly, about 90% if you go across various literature. And so this is a condition which, in fact, MRI can miss out at a good number of times, right? So you can see complete discontinuity of the tendons. You can see this boomerang shape of the tendon where you have the peroneus brevis, surrounding the longus. You can maybe identify a change in caliber of the tendon. There's separation of these fibers into discrete tendons. And yes, you can have tenosynovitis as well. But still, the sensitivity and the specificity of ultrasound of MRI
तुझ्या
is
गाडीची किल्ली कुठे
हा?
तुझ्या गाडीची किल्ली कुठे
माझ्या गाडीची डुप्लिकेट घे ना आणि परत तिथेच करून दे.
in fact, if we go back to what was there on the MRI, I'll just try to bring that up correctly,
Oh,
right? They had actually mentioned that there's thinning of the tendon. They had mentioned about the tenosynovitis. Okay, but this tear hadn't been reported. Okay, so we went back and just had a look at the images. I'm not an expert in MRI, but I believe if you carefully scroll over it, sorry. There is probably this area where you can see a small split of the peroneus brevis actually happening somewhere over here at this level in this frame. So yes, potentially this could have been diagnosed, right? So in terms of the management, first, obviously, we always try a conservative management. So you give anti-inflammatories, you do physiotherapy. In fact, this patient has undergone physiotherapy, has been on rest, and has had an improvement in the pain component. She hasn't been operated as of now. And so we'll just see how things are happening. But in terms of the surgical approach, of course, they have to repair the tendon. But what is also important is if there is associated tear of the ligaments or the peroneal retinaculum, that has to be repeated as well. So this is just a short case, but what I was just trying to impress upon was the impact, sorry, that ultrasound can really have in these kind of cases. Thank you.
मैसेज करना होगा हम पहचान नंबर
Excellent, Rajas. Wonderful. Loved it. Any questions? Anybody? Because you see, peroneal is something that we don't see very often. So when you have a direct trauma, you would probably have peroneal retinacular tears and therefore subluxations. But therefore, it's one of those rarer things. But I think the way it has been explained, the anatomy and the images were very crisp. But anybody has any questions, please feel free to ask.
You can even type it in the chat box if you want, please. Word.
Okay.
Rajesh,
so
I will-
was there any instability also, or it was just a
No, sir.
vertical split? On dynamic, was there any subluxation or a
No, I
dislocation?
couldn't.
No.
No, I couldn't identify anything as,
Yeah.
and even a, yeah. So it was more
So,
of only that I could see. So probably this was because of the chronic application.
so much tenosynovitis with so much tendon sheath thickening, maybe subluxation would not be appreciated. But I was asking Rajesh that, okay, so you talked about boomerang sign and then you showed us complete split. So is there a stage difference between the boomerang sign and a complete split? Because boomerang sign will show some sort of continuity posteriorly.
Yes.
the boomerang is more with the thinning, and there is no,
Correct.
it's a atretic tendinopathy will give boomerang. And when the split
But
occurs,
they
you
should,
see too many tendons in the
huh,
retromedular go. So that's how
correct.
when you see more than two tendons, think about it, possibility, and
So
sometimes along
what
with
I'm
the
asking, hmm,
yeah,
sorry, sir. Yeah.
along with the peroneus brevis, sometimes you may get even the split of the longus also, because
Yes, sir.
what happens because of the continuous invagination of the longus within the split tendon, there could be a secondary atretic tendinopathy and a split of the longus also. So instead of three, you may see four tendons also in the retromedular group. That's how.
So my discussion is moving around that if you see a boomerang sign,
Yeah.
do we say that there is a thinning without a tear, or that there could be a partial tear? Because then prognostication is totally different, sir. No, the prognosis becomes absolutely different if we are saying. So does an atretic tendon also will show the same boomerang sign and without a tear, thinning of the tendon, but without a tear?
Yes.
That's
Yes.
my question, because it doesn't say anywhere in literature how we interpret boomerang and how do we prognosticate it to the surgeon. tear to tear ho
Okay.
gaya.
Mm.
But for the boomerang sign, and you
Yeah.
come across boomerang sign very often, sir, in elderly ladies. I
Right,
have
right.
seen this. The ones who come with chronic instability,
Yeah.
boomerang sign दिख जाता है, but you don't know what to tell to the surgeon that ये tear है, ये thinning है because
No,
of overuse syndrome.
I will put it as atretic tendinopathy. I will put it as
Correct.
atretic tendinopathy, you know.
Right,
If I,
right.
yeah. So what was the cause in this case of the split? Was there any morphological changes in the retromalleolar groove? Any osteophytes?
sir.
Because on the MRI, I did not see any osteophytes or anything, you know.
No.
So,
So probably it's been, I honestly don't know because maybe it was overused, but there was no specific
over,
history. Tried
overuse
asking.
means,
How old was the patient,
But
Rajesh?
was,
sorry,
How old?
no, she was about 40-ish,
Ah.
not
so
very.
partition, she's not an athlete, right? Not an
No,
athlete, right?
no.
Yeah, so it's a history is very important. It's very common among the tennis players and badminton players. They because of the repeated inversion, they do, and if this is associated with underlying changes in the morphology of the groove. Some people have a flat groove.
Shallow groove, yeah. Shallow groove.
Absolutely, sir.
Yeah. So then I think it's very important.
Then also generally, I mean, whatever literature I went over, I think
Yeah.
the athletes and all, they also have other complicated things invariably. But the ligaments were okay, the peroneal retinaculum I couldn't,
Yeah.
tear. So generally the
No.
injuries.
You know what, Rajesh? I loved Sir's first question. Was there a subluxation? Because when you have a shallow fibular groove, that shallow fibular groove in itself causes that repeated subluxation. In fact, you can actually feel the click under your probe. And then it sort of, over the period of time, it tears. Yeah, the overuse. So that was a very interesting question. But now she was landing up with so much tendinopathy.
Yeah, I was going to ask, I mean, injuries.
Hi, Bharat. Hi, Bharat. How are you? Can you mute yourself? We can't hear. Hi, Bharat. Bharat, can you please mute yourself? Or if there is a question, come up with it.
Bharat Anna, mic mute ಮಾಡಿ ಅಣ್ಣ.
I remember Martinoli talking for an hour and a half on only lateral ankle in one of the ultra fest, and it was so mesmerizing, the number of cases he showed. He showed the prominent peroneal tubercle causing the split of the peroneal tendons. It was really a wonderful talk, I still remember that lecture of his talking about. Good case, I think,
Very good case, sir.
Very nice case, yeah. So this is the case where ultrasound scores over the MR,
That was the reason.
The resolution is better. The dynamic nature of the modality is also advantage to ultrasound. Yeah.
Rajesh, do you grade the tears? Do you grade these?
So grade, I'm not sure on ultrasound, but on MR, they have reported in terms of the length of the tear. So if it is only a partial tear, then you have a tear which is, I think, less than 1 centimeter in length. Then the second is if you have more than 2 centimeters. That was one of the gradings which had been mentioned.
I think grading also talks about the injury to the peroneal retinaculum. I think there are more than, there are 5 or 6 grades of the peroneal tendon.
Yes, there are 4
exactly. But it does speak about the injury to the peroneal retinaculum.
Correct.
And then the subluxation and dislocation of the tendon.
Right, sir.
Yeah.
Great, Rajesh. Absolutely
Okay.
fantastic.
Excellent.
Thank you.
So,
Thank you.
Good.
So
If there are no questions, yeah.
Yeah,
We
I
can
think
go
Dr.
to the
Suvinay
second.
said there is a grading on peroneal tears on ultrasound as well. So I think if you can share it with all of us, that would
Yeah.
be great. Thank you. So, so I think the next lecture is going to be taken by Dr. Suvinay Saxena. He's going to be presenting on shoulder. So Dr. Mohit is going to introduce Dr. Suvinay Saxena.
Yeah, Dr. Suvinay Saxena, I met this guy for a period of time. I've, absolutely fascinated by his work and his dedication. He wants to be a dedicated MSK radiologist in trust. Believe me, he tries very hard for it. He gave a wonderful lecture in the national conference in, this last month. And I am happy the way the younger generation is shaping up. It really gives you tremendous amount of satisfaction to see these guys come up, do excellent work, and have the confidence to present it to a larger audience. Fantastic work, Suvinay. Please carry on. Show us the interesting cases, please.
Thank you so much, sir. Very good evening to one and all. I'll just take a moment and try to share my screen. Can the host please allow me to share the screen?
Hussaina,
No, Hussaina is not there, so I'm just going to make Suvinay. Oh, sorry. Sorry. Are you able to do that now, Suvinay?
Yes, yes.
good. Excellent.
Is it visible now, sir?
Yeah, it is. It is.
Let's see.
So thank you so much, all the senior dignitaries and all to allow me to present on such an esteemed platform. Although I wasn't aware of the level of cases that need to be presented, so I am just presenting few of the basic cases. Maybe in future sessions, I would try to present more interesting cases. So the first case that I have was a 53-year-old female who presented with neck pain to the department, and the pain, she complained that it was radiating to back of the shoulder, and the cervical MRI that was done was reported as normal. And then, as because of the financial constraints, we went ahead and did a shoulder ultrasound for the patient. So before starting the shoulder ultrasound, I always tend to look at the radiographs and try to identify the findings. This is what my teachers have taught, and I always try to use radiographs before doing an ultrasound. So I'll just give a moment to everyone to just please try to go through the radiograph, maybe try to identify few of the findings that are seen here, and we'll come back to the radiographs later. So I started with my standard screening of the ultrasound with the anterior approach, visualizing the biceps tendon in the bicipital groove. Then we went ahead and also I evaluated the subscapularis tendon, the supraspinatus tendon. So subscapularis and supraspinatus were normal, but uh, when I went ahead and tried to evaluate the infraspinatus tendon, there was this focal hypoechoic area, which I can see here along the an insertion site of on the insertion site of infraspinatus on the middle facet of the greater tuberosity, and this seemed to be suspicious. And I tried evaluating it, and definitely, according to me, it was a full thickness tear of the infraspinatus here. And I just when I went ahead and did a longitudinal view, I could not see the tendon at this point. So then I went ahead and tried evaluating the muscle bellies of both supraspinatus and infraspinatus. So I could see that there was some hyperechoic areas within the infraspinatus here. And these are few of the elastography images that I tried to use to come to a diagnosis. And this was a normal contralateral side of the infraspinatus. And as this lecture, I thought I'll be showing basic things. So I've just added few like panoramic view and all. So this was the pathological side, and wherein we could see that the tendon, infraspinatus tendon was retracted, and the area we could see a fluid-filled area cleft with the retraction of the infraspinatus. I'll just try to see if the dynamic. I'm sorry, it's not working, sir. But we did the dynamic scan, and this was the true extent of the tear. So it was a complete full thickness isolated infraspinatus tear with retraction, and according to me, grade 2 atrophy on an ultrasound with subacromial subdeltoid bursitis. So the clinician wasn't convinced of an isolated infraspinatus tear, and they wanted to plan a surgery. So they went ahead and did an MRI. So this was the MRI for the case, and these are axial and sagittal proton density images wherein we can see that there is complete full thickness tear of the infraspinatus, and this could very well be seen on the ultrasound images also. And the grade of fatty atrophy according to an ultrasound, I had labeled it as 2, and because it was involving more than 50 to say percent fibers of the infraspinatus, and like these were all my findings for this case. So why and finally I confirmed it that it was an isolated infraspinatus rupture. Although in literature it has been told that the isolated infraspinatus tears are relatively rare, associated with calcific tendinitis often, and have a good treatment outcome when they are operated. So, sir, this was my first case. So, would you want me to go ahead with other cases, or would you want to discuss this case again?
I think maybe we
Let's
can.
because I think let's discuss this case. Anybody, what was your finding then retrospectively about the plain X-ray?
Yes,
Did
sir.
how was it read?
Sir, so in this there was a small this subacromial spur-like area here, and
Yeah.
so this can be a secondary indicator of a chronic stress to this patient, and can cause long-standing tendinosis to the patient, and then that might have resulted in a tear because she wasn't an athlete, sir. She was just a like she was a worker, 53-year-old worker. So I think we should be careful of these subtle sclerosis that we are seeing here, and
Yes.
these
Yeah. So there is a subchondral sclerosis and
Yes, sir.
the spur from the lateral edge of the acromion, which
Yes, sir.
probably prompted there has to be underlying some form of a rotator cuff disease. It could
Yes, sir.
be anything tendinopathy versus tear. So plain X-rays are very informative with this patient. And of course, the outlet view does not show any abnormality in the anterior one third of the acromion, but there are the changes of acromioclavicular joint osteoarthritis.
Yes, sir.
Now
Yes,
I think the isolated tears of the infraspinatus commonly seen among the patient who had a fall. It's
okay.
otherwise most of the time it is like an extension of a degenerative tear of the supraspinatus. But
Yes, sir.
isolated tears can happen in a patient who has a history of a fall. Right?
Yes, sir.
That's a very important history to ask for, according
Yes,
to
sir.
me. Yeah.
Okay.
And normally the infraspinatus is a 2 to 3 times larger than the corresponding teres minor. So if
Yes,
you
sir.
see the infraspinatus either equal to the teres minor muscle belly, you have to think about the possibility of the volume atrophy.
Yes, sir.
That's what.
Okay, sir.
Yeah.
Thank you so much.
Mhm.
So there's one more
So
thing. So what you showed is, that sclerosis along the inferior aspect of acromion that's also known as a sourcil sign. I mean, it's
Yes,
just
sir.
an
Yes.
academic
Yes, sir.
thing. You don't have
Yes.
to know the name. SOURCIL, sourcil sign.
Yes,
That's
sir.
what
Yes, sir.
it gives you, that there's some kind of an rotator cuff thing, pathology. And how old did you say this patient
She was
was?
53-year-old female. 53.
53. Uh, Another thing with these infraspinatus tears is that initially we used to feel that all the tears begin from the supraspinatus, the anterior edge. But if you look at the new literature, they say that it's not the anterior edge, but most of the tears, they begin in the region of the composite tendon, where the supra posterior fibers of supraspinatus
Yes, sir.
and the anterior fibers of infraspinatus. So most of your degenerator tears will begin from this area. And of course, they could go in either direction, anterior or posterior. So maybe if you look, keep a look at the disease pattern where there's no trauma involved, you will see more and more of, infraspinatus also getting involved. I mean, that's what I feel. Yes.
Yes, sir.
Sunay, you need to improve upon your outlet view. This is not
Yes,
the
sir.
correct view.
Yes, sir.
I
Yes,
think
sir.
you need to teach your technicians how to take an outlet view. If I look
Yes,
at
sir.
this outlet view, I will feel that there is a superior migration of the humeral head,
Yes, sir.
and
This
but
is correct. Yes.
it's taken in exactly opposite way. You
Yes,
ideally
sir.
you must see a very good coracoacromial arch with the humeral head below the so I think next time try to get a
Yes, sir.
better outlet. Yeah.
Definitely.
But this is
Definitely.
a very, very, very good transscapular view.
Yeah, it's a good
I mean, it's a
transscapular.
Yes, sir.
fantastic view. It's a
Yes,
fantastic
sir.
transscapular view.
Yes,
Yes,
Yes.
sir.
yes, yes.
I'll go to the second case. So this was a 33-year-old patient who was referred to us with severe acute pain in the right shoulder, and he wasn't able to lift or move the shoulder and presented with his arm in a sling. And on examination, there was complete loss of range of motions. Patient was having severe pain, and basically patient had come for a MRI review to us. So, but went ahead and started with an ultrasound first. So I'll show you the ultrasound. So this was a short axis view of the biceps tendon. So although we are seeing anisotropy at the level of biceps tendon, that was deliberately done to show something else. So what we are seeing here is an echogenic component or an echogenic area adjacent to the biceps tendon, and so this is that same echogenic area with some amount of subacromial subdeltoid bursitis here. And this was the supraspinatus of the patient. I really struggled to get a good cross or modified cross position for this patient. But what I could see was that there was extensive tendinosis and these echogenic areas present within the tendon. And then apart from that, we had this subacromial subdeltoid bursitis. And further trying to get better images, I could see a confluent echogenic area here. And there wasn't any significant increased vascularity on the color Doppler images. And elastography, I wasn't sure of my findings that whether this area should appear hard or not. So I just attempted elastography in this. So the diagnosis was clear, but for the purpose of residents or beginners, the diagnosis would have been much easier if I had seen the radiograph first. And so always if we again start, this was the outside radiograph the patient had, and this was what we could see are these confluent calcific foci along the area of the rotator cuff, and this was basically calcific tendinitis or hydroxyapatite deposition disease with with migration along the subacromial subdeltoid bursa, and also the migrated calcium was seen near the biceps tendon sheath. And these were the MRI films that the patient had, and we could see extensive subacromial subdeltoid bursitis, and the supraspinatus tendon here has extensive tendinosis with hypo-intense areas within. So this is the supraspinatus here again with, and this calcification has gone from the articular from the up to the bursal surface and is inciting lot of inflammation and causing bursitis. So due to my teachings in UCAM and from the Musculoskeletal Ultrasound Society, I recommended doing an barbotage for this patient, and this was what we used, and I went ahead and tried aspirating it with. I went ahead and pulsated it with first lignocaine within, and eventually I tried to aspirate as much as I could. So these are a few of the images, and I tried aspirating it out using pulsation technique, and we can see the hyperechoic, sorry, this calcium coming out in puff of smoke appearance here, and this we could see it settling down and forming flakes, and I am just pulsating it, and ultimately this was how much I could take out from this patient for around 15, or I attempted 10 to 15 minutes, and this was the pre and this was the post. Although I could not remove the entire thing, that this part was what I could remove, and I ultimately ended my procedure by doing a subacromial subdeltoid triamcinolone injection, and this was the patient after 3 days, and we could achieve some degree of external and internal rotation to the patient, and also we could achieve at least 90 or approximately 85 to 90 degree of abduction for this patient. So this was the case, sir, and now maybe, sir, please, I would want you to guide me on how to proceed, and whether we should attempt taking out the entire calcification, and how to go about it, sir.
This is a classical case
Yes, sir.
where typical presentation, and as I say, you don't need investigation. It's a clinical
Yes, sir.
diagnosis.
Yes, sir.
Investigations are done to confirm the diagnosis, and I'm sure the intervention is just piece of cake here, because most of the calcification look like a soft calcification,
Yes, sir.
and
Yes, sir.
aspiration is usually easy in this kind of patient, and it's very rewarding. Patient goes back from the clinic almost pain free, after the procedure. Then
Yes, sir.
worth attempting. So Ankit, say a comment. Is he there?
Yeah, I think there's a very well done procedure. So very good correlative imaging, X-rays, MR as well as ultrasound. And I think yes, what Dr. Suvinay said is that yes, we should look at X-rays because they're going to help us in a big way. Because a lot of times as a beginner you might struggle just on the ultrasound images, but if you have the radiograph, the diagnosis is obvious. In fact, sometimes this calcification they're missed completely on MRI altogether itself. And yes, if you're doing this barbotage, it's a fantastic uh, procedure to do. But Suvina, I feel that even when we try and do, it's not possible to remove all the calcification. I mean, you have such a big chunk of calcification.
Yes, sir.
So, uh, uh, you know, we should have a realistic goal at the end of the procedure that I'm going to remove as much as possible because some of the calcium is going to be paste-like, some of it is going to be hard. You don't really want to do too much to the tendon because
Yes, sir.
ultimately, see what you're doing is you're creating a cavity inside.
Yes, sir.
Uh,
Yes, sir.
and see, your job is not to basically your job is to debulk that calcium. You try and remove that much. At the end, it's the steroid which is going to have that action.
Yes,
So
sir.
there will be times when you are unable to aspirate even after the pro- procedure. If you take an X-ray, it's just going to look like that. But let me tell you, if that same patient which you did the needling, if you do his radiograph after 2 weeks or 3 weeks, you'll see that there's a significant difference. Although you may have not been able to remove much calcium. So it's just that maneuver of you doing that intervention, breaking it up, inciting inflammation, that can help in a big, big way. And of course, it's a steroid which takes care uh,
Can
of
I
that,
have a word,
that
Ankit?
pain. Yes, 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 sir. Please.
Yeah. So, as Suvinay said, see, the
Hmm.
success rate is much higher in type 2 calcifications. If you
Yes.
deal with type 1
Yes,
calcification, which is stony
yes.
hard in appearance, it is advisable to do fenestration without keeping much, without expecting much yield of withdrawal or the suction of the calcific deposits. But type 2, this, whatever you have done is quite good enough. Remaining calcification will definitely get reabsorbed within a couple of months' time. So for type 2, this much is quite good enough for relief of the patient, and usually this doesn't recur. But type 1, again, there is a limit. How many times you go in and which number of which bore needles you use. I usually start with smaller bore needle and then go on increasing the gauge of the needle to maximum 18 gauge or something. But I usually initial puncture is with 23 gauge needle and lignocaine and saline puncture it.
Yes, sir.
That first puncture, whatever amount of local anesthesia you give, the first puncture into the calcium is always very painful. And that is the indirect sign that you have actually hit the calcium. The moment you puncture the calcium and inject little bit of saline and lignocaine into it, patient really screams. And I mean, it's an indirect sign that yes, you have hit your target. And then you slowly keep on doing the pulsation technique and try to aspirate. But good success rate, if you count, is in the type 2 calcification, which look more like a slurry type of calcification. But type 1 are sometimes very difficult, and then you have to really think how many times you are going to go in. Just fenestrate them, and then even then the patient will get very good relief. And after 3 to 4 weeks, he will progressively improve.
Thank you, sir.
So
So,
here is a question, Suvinay.
yes, ma'am.
You said intraosseous migration. You saw the intraosseous migration.
No,
Did
ma'am.
you?
Along
No.
the bicep
No,
sheath, ma'am. Not
My share. No, there is
You
no
saw.
intraosseous. My
in,
MR does not show any
ma'am. In this case,
intraoperative.
there was
Exactly. I
yes.
heard that probably you said,
No.
No, ma'am. No,
Eh,
no.
but I could see
yeah,
that on the ultra. You
yeah.
said it was in the biceps tendon sheath.
Yes, ma'am. It was going
Yes.
into the bicep sheath. Yes.
In the biceps sheath.
Yeah.
Can you just explain the pathophysiology, the pathogenesis here? I mean,
Ma'am,
so you said primarily you thought that this was a calcific tendinosis
yes, ma'am. Of the supraspinatus.
of the supraspinatus.
Yes, ma'am.
From the supraspinatus, intra-substance calcific tendinosis of supraspinatus. That's what you
Yes, ma'am.
said.
Yes, ma'am. And
Well,
then went to the bursal surface, inciting inflammation and causing subacromial subdeltoid
yeah,
bursitis.
you said inflammation, but you could not raise any vascularity there.
Yes, ma'am. In the tendon, I couldn't get. Yes, ma'am. This
In
was
the
the
tendon.
vascular. Yes,
That's
yes,
not
ma'am.
vascularity. That looks normal. Anyhow,
Yes, ma'am.
was the patient very symptomatic at that point?
Yes, ma'am. He could not. The patient was brought with his arm in a sling, ma'am.
Yeah, exactly. That's my point. So then from there you said that it migrated into the biceps tendon sheath?
No, ma'am. In the initial presentation itself, I thought that some calcification was near this was the biceps tendon here, ma'am. I thought the calcification has already migrated into other parts of the bursa and is close to the biceps tendon.
Okay, maybe I heard it wrong because I just couldn't understand where you were connecting the dots. I just couldn't
Yes,
get
ma'am.
at that point.
Yes,
Yeah,
ma'am.
so okay. So
I
primarily
got your
we're dealing with the calcific tendinosis of supraspinatus.
yes, ma'am.
And you went into intrasubstance and you tried to break that
Yes.
thick calcium. Were you able to grade when you were doing it? Were you able to gauge, as Dr. Ketkar said, whether it was type A, type B, what kind?
It
Was it
started
soft?
coming out, so I thought that some part was definitely type 2 inside
Okay.
because but because it wasn't like slurry, ma'am. It came out in a powdered form later on.
Okay. Right. Okay. Thanks. All right.
So,
So yeah, so
this
what suvinay showed is, sometimes it's not clear cut where the calcium has extruded, because from the tendon it can just go anywhere. It can even go in the biceps tendon sheath. It can go within the rotator interval, in the bursa, and in the peribursal planes. Okay, so it's not neither in the bursa nor is it within the tendon. It's somewhere. Sometimes it's over there as well. So yeah, there's not
Ankit, I
you
beg
cannot
to
have a clear
differ.
cut
Ankit, I
mark.
beg to differ. It does not
Yeah.
migrate. So you have multifocal deposits that come. But the migration, the intraosseous one, where it goes and transcends from the bursa into the tendon and into the osseous structure, that continuation we can understand. But that part where we say migration, there is a very large study which says that these are usually multifocal deposits instead of migration of the crystals. I
No,
mean, this is, yeah,
but when you say in the bursa,
yeah,
that has to be migration. It cannot calcium cannot deposit in the synovial membrane as such. So it has
yeah,
to be the migration. So the most two common sites of migration is the bursa and the intraosseous. And
correct.
nowadays, we are seeing very commonly in the rotator interval. Extending into the rotator interval. Uh,
Mm-hmm,
this is very common. Maybe it's because of the improvement in the transducer technology. I think we see
mm-hmm.
very frequently the crystal deposit in the coracohumeral ligament and extending into the rotator interval. Very
Yes, sir,
frequently. Yeah,
perfectly.
yeah,
I totally
yeah, yeah.
agree. I totally
Hmm.
agree with multifocal deposits.
Hmm.
That part is understood. And
Yeah,
yes,
yeah.
subarachnoid subdeltoid bursa, which can be a sympathetic response or it could be a direct continuation. But
Okay.
again, so there are
Hmm.
there are varied views there, whether it's a
Hmm.
migration or they are individual deposits. So, I mean, we cannot so dogmatically say that there is a migration
Hmm.
unless, of course, that intraosseous one is a proven fact.
Yeah.
I
Great
got it.
So in
suggestion.
fact,
Great.
in fact, what happens is, a lot of time, at least before I do a procedure, even if the patient has a radiograph, we do a baseline X-ray. So a lot of times, what happens is, let's say we've done a sonography and we've said fine, he has calcific tendinitis. Then they go to the orthopedic surgeon, and then the orthopedic surgeon says, fine, you do a barbotage. The patient comes after a week or 10 days later, and then what we see is, even before we start with the barbotage, when we do that radiograph again, there's a definite change in morphology. In fact, you feel that some of that calcium in the tendon has changed. Some of it has spilled out more in the bursa. So that's where my this thing understanding of this spillage comes out from. That's where I feel that there's some change. So it was there initially, and now it has more in the bursa and so on. So yeah, that's what I feel. And sometimes, when you're scanning, you'll see that some of that calcium along the bursal surface fibers is partially protruding into the bursa as well. So maybe something is happening over there, especially with the slurry kind of calcification.
Yeah.
Ankit, what is your experience on which is more painful? I mean, intratendinous calcification is more painful, or when it migrates into the bursa, the symptoms are more aggressive?
The
Subchromial.
bursa,
Bursa.
Versus,
bursa,
Bursa is the primary
bursal.
brain generator. Mhm.
Yeah.
this was just a simple spotter in which there was a large paralabral cyst with a posterior labral tear in a cricket player who wanted to resume playing as soon as possible and was advised surgery, but he wanted to resume playing. So we did a decompression of the cyst, and the patient was symptomatically better. I have a better case now. So I wanted to discuss this. Our 20-year-old passionate gym goer, and he had a history of jerk and then presented with persistent shoulder pain. there were no restriction of movements, only posterior shoulder pain to the patient. And these are the normal, I scanned everything. So all the tendons were normal. What I could find was there, so there was this relative fatty atrophy of the teres minor muscle, which when I compared it with the other side, and this is what I could identify, that the teres minor was relatively atrophic. And although the patient was a 20-year-old male, and he told that he had slight jerk, but there was no significant dislocation to the patient. And I tried evaluating the axillary nerve then, and this was the axillary nerve along the uh, just posterior to the humerus, and the cross-sectional area was around 6.5 millimeter squares. So what I was thinking as of now was maybe the axillary nerve should appear to be more hypoechoic, and I should be seeing some more abnormality on an ultrasound, because as per the literature, the cross section, the area is around 3 plus minus 1, and this was the video for this case. I was trying to trace and identify any abnormality in the axillary nerve here, and I have the MRI. I'll show the MRI also. So these are the axial proton density images, and this denervation along the teres minor is pretty clear in this image. So we can see that there is some hyperintense edema along the teres minor muscle, and we can see that on the sagittal images again, that the muscle appears to be hyperintense. But when I was doing an ultrasound, I could not find any lesion along the quadrangular space. And on MRI also, I could not identify any lesion along the quadrangular space here. So I have just kept this case to discuss with the seniors that should we be confident enough and label this as a quadrangular space syndrome or quadrilateral space syndrome, because the nerve appeared to be relatively hyper bulky on an ultrasound, but I wasn't sure, and I had requested an MRI for this patient. So this is the corresponding coronal MRI again, and this is the denervation pattern. What we are seeing, so isolated teres minor denervation, and deltoid was normal in this case.
So you may not have any structural abnormality. MRI
Yes, sir.
definitely shows that there is a denervation injury selectively
Yes, sir.
affecting the teres minor. So
Yes,
I
sir.
would put it. Suppose if there is some viral pathology, like a parsonage Turner syndrome, where of course
Yes,
you
sir.
get all the muscles involved, but here there is a isolated injury. I would think even
Sir,
though there is no structure, yeah,
I inquired with the patient, sir, and the referring orthopedician, when he examined, he told that he had some sort of multi-directional instability. So his joint, like shoulder, was slightly lax and hypermobile. So can
yeah.
this cause some sort of like grade 1 injury, neuropraxia sort of injury to the axillary nerve, and then causes?
Very difficult to.
Yeah, so see, you
Uh,
can have a mononeuritis is possible, just single
mm,
motor nerve isolate. It is possible because
Yes, sir.
once in a while you do come across involvement of just anterior interosseous nerve involvement, or just a single motor nerve fascicle is involved. So possibly there's
Yes, sir.
nothing at the level of the quadriceps, but sorry, quadrangular space, but that single motor branch to teres minor could be, involved. That is, of course, MRI makes things much more clearer,
Yes, sir. For this,
and
case, so I
it is.
recommended doing an MRI for this.
So maybe the entire axillary nerve was not involved because the deltoid muscles are spared.
Yes,
So
sir.
they are,
So most possibly the posterior division of the
yes,
might, yes,
Yes, yes,
might.
yes.
true.
That's it, sir. Like these were my cases, and as I recommend seeing radiographs, and ultrasound is again a
Yes, yes.
beautiful tool that allows us to evaluate patients clinically and evaluate respective pathologies, do dynamic ultrasound, and compare with the contralateral side. Thank you, sir.
Yeah, good cases.
Good.
I'm
Superb.
happy to see true AP view of the shoulder.
Yes,
You know, at least now the next thing is you need to do a good outlet view. But it's
yes, sir.
I
Right.
think we need to migrate from obtaining oblique AP view to a true AP view, because then it's a very important, because that gives you a really good profile of the glenohumeral joint and the acromiofemoral distance and all. Yeah.
Thank you,
Your
sir.
last case, Suvinay is a winner.
Yes.
I
Yes.
I just added it. I didn't know like how the presentations are from. Next time I'll also add few more such cases.
Truly a winner. Absolutely fantastic. Absolutely fantastic. This is because I missed this case once so badly. I mean, so you're doing it and you felt, I mean, I did feel, and then quadrilateral space, I don't have access to MRI. Anyhow, the patient came back with teres minor. And when the posterior branch is specifically involved, and it can be involved, particularly these men don't realize when they're doing these what do they call? ये तुम लोग क्या कहते हो? What are those?
Bench press, bench press or
Yeah,
shoulder.
exactly. Bench
That
presses.
this patient had same history.
Yeah, so you do those bench presses and you don't realize the kind of stress you're taking on a posterior shoulder. And then he came back. So absolute winner. Great case. Maja aa gaya.
Yeah.
Congratulations.
Now we have to pay a lot of attention to teres minor,
Correct.
Yes, sir.
Earlier, if you read earlier literature, they thought teres minor is not a very important tendon. It gets involved only along with the other rotator cuff. But now we do see the isolated involvement of the teres minor. Secondly, when patient who has already injury to the complete tear of the infraspinatus, the teres minor is the only external rotator which is left, And so if surgeon is planning to do some tendon transfers or something, they need to have information about the teres minor. So
Yes.
all our ultrasound examination must look at the teres minor, and if you find isolated involvement, you must look at the quadrilateral space also every time, because it's a very easy looking at the quadrilateral space doesn't take more than 5 seconds.
Absolutely.
You just extend your posterior quadrant examination laterally and look at the quadrilateral space,
So,
and I'm sure sometimes you may come across some surprises.
no, sir, absolutely. It's a total story about mind and eye coordination.
Yes, yes.
So,
Yeah,
if
so
we have it,
now we have to look beyond the protocols which are suggested by the European Society of Skeletal Radiology.
so बहुत
Now,
पीछे छूट गया. Looking at the latest generation of UCAM graduates, sir,
yeah,
मुझे लगता है ये
yeah,
साल बहुत backspace ले गया. These
yeah,
guys, they can write their own protocols now.
yes, yes, yes. No, and frankly speaking, what we teach or what ESSR protocols are too basic in today's practice. What we see references are very difficult. Our basic knowledge is not enough, because now we see so many complicated cases which are already MRIs are being done and patients are referred to ultrasound as a problem solving modality. I'm telling you, orthopedic surgeons are well versed with the applications of ultrasound now. Those days are gone where they used to ask MRI first and always MRI. Now they ask ultrasound as a first imaging modality in so many places,
Absolutely.
particularly when you look at the hand and fingers, you look
Yeah,
at the ankle, and a lot of places ultrasound is preferred over the MRI.
totally.
So onus is on us to give very excellent diagnosis. We have to graduate ourselves from the basic protocols to advanced studies, and yeah, that's the thing.
Completely agree, sir.
Yeah, sure.
Great. Thank you, Ankit.
Great,
Wherever you're
great.
sitting. Ankit, you are joining us from Norway?
Yeah,
Yes,
he's
yes, that's
Not bad.
yeah,
मेरे को भी चलना था, पता है? I want to run away from all
madam.
this. Yeah, so
अरे आप yes, the weather is good. You can come down.
I'm sure. Chalo, you enjoy yourself.
Yes. All right. Thank you, ma'am. Yes.
Thank you.
Right. I think
Okay.
If
these
there
are
are no
great
more
cases by
questions,
Rajas and Suvinay. Yes.
Thank you. Thank you.
Who are the volunteers for next week?
So
Volunteers?
next week we don't have. Next week
Okay.
we don't have. So I think we still have to plan. So I think
Yeah,
this
we'll
month
plan
we
that.
finish 2.
Yes. So
Yes.
we'll keep
So
everyone
next month
updated.
we'll have.
And I would request anyone, anything you
Hmm.
want to present, please get in touch with me or Dr. Ankit, Dr. Upasna, Dr. Gina, any one of us.
Hmm.
And I think are able to get more people to present. So
Yeah, and it need
Yeah.
not be extraordinary cases.
yes,
Even the
absolutely.
simple day-to-day cases are good for the discussion, Yeah, sure.
totally.
Okay.
Okay.
Yes.
Thank you so much.
Okay. Yeah.
Okay, bye.
Yeah.
Good night,
Bye.
everyone.
Bye. Good
Bye.
night.
Right. Good night.
Bye.
Thank you.
The last vessel to arise from the aortic arch is the apparent right coupling.